Universal steps for safer patient procedures. There are many safety risks associated with a clinical procedure. Not all of them can be predicted, but there are things that are under our control. Though it may seem simple, the promise to prevent wrong site, wrong procedure, or wrong person surgery is one that our clinicians take very seriously.
Now, there's four basic components. The first one is pre-procedure verification. We look at the consent, we look at the patient's history, and we use the consent as a tool, especially in the clinic where we're obtaining the consent to verify that we're doing the correct procedure on the correct patient. The second component is and then this applies only in the clinical setting, if the surgeon leaves the room, that when they come back, then they mark the site. Now, in the OR, the site is marked before the patient ever gets into the room, so that's not as much of an issue. The third component is that we do a timeout, so that before the procedure actually begins, and it's usually the nurse in this case would say, all right, timeout, is this the correct patient? Is this the correct site? Have we given them the right medications? Have they gotten their antibiotics? Are they positioned the way we want them? And then the final component is that we have to document very clearly that all the steps have been taken place and the appropriate staff is signing that document.
An example of universal protocol before a clinical procedure.
Good morning.
Good morning.
And what are we doing today?
I'm checking lymph node on left side.
Left side? Okay. What I've got down on our consent for you is going to read a fine needle aspiration of a left neck mass. Okay? Risks to you primarily are that of bleeding and infection. We are using a needle, so there is a chance of getting an infection. And what you would notice is that you may get some swelling afterwards and maybe some increased tenderness or redness. And we'd want to hear about that. Any questions about what we're going to do?
No.
All right. I need your signature there, giving me consent. And that reads a fine needle aspiration of the left neck mass. Okay. And just before we get started, I'm going to make a little mark just to make sure that we all agree on where the site is. And let me just put a little bit of alcohol over that area for you. Okay, and before we get started, we'll do a quick timeout.
Okay, we have Casey Barnes, date of birth 6/4/83. We're doing a fine needle aspiration of the left neck mass. Casey, do you have any pain right now?
No.
Okay.
Okay.
So you'd rate it at what out of 10?
This was 0.
Okay. Perfect.
All right.
Okay.
So we're all in agreement.
Yes.
Okay. The problems are the same whether we're doing the procedure in the OR or in the clinical setting. The issue is that in the OR we have a great deal of standardization. We have a lot of backup systems because this is a site where very serious complications can take place. The problem in the clinical setting is that we don't have those standardized processes. We don't always have the same personnel that are there all the time. So, and the complexity of the procedures are not as great. So maybe the level of awareness is not as heightened as it should be.
Does not matter where you work. You do the same sort of questions. You always ask the patient their name, their birth date, and what are we doing for you?
Just because we haven't had an event for a particular surgeon doesn't mean we shouldn't take those safety precautions. If you think, is 1% of a time, is that too little? Well, that's one person out of 100, and we're talking about people, so that's a real number that's significant.
With any procedures, anything invasive in the ICU, which happens quite often, if it's not emergent, we have a full written protocol, talk to the family. Even if the patient's sedated, we let them know what we're doing. And then before we do the procedure, when we're actually ready, then we identify our patient with 2 identifiers, whatever they may be. It's usually our provider who verbally does that so the patient can hear that. And we actually, if it's a side, a right or a left, then we also identify which side we're doing the procedure on. And we write that time, and that's kind of our timeout, and anyone in the room who's there, even though the provider does it, can stop that if they're concerned that it's not the right patient or the right procedure.
Following a universal protocol matters to our patients.
I think it's very comforting if the patient is able to hear us, for him to know that, one, the provider knows who the patient is when we do the identification with date of birth and the name, and also very comforting for the patient and the family to know that the provider actually knows what he is doing. He knows the site, and he has taken all measures to make sure it's done safely. So it's not only a safety issue, but it's also very comforting for the patients.
I've had a case where we had a nurse actually that was grumbling about the universal protocols, and the patient said to the nurse, "Hey, I really appreciate this. This tells me that you're taking time to really make sure that I'm safe." And we all kind of stood back and went, "Well, okay, this really does make a difference."